The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety. This is the Flight Bridge Ed podcast, critical care and emergency medicine education for nurses and paramedics.
Hey everybody, Eric back with you today. Real excited to have Scott Weingart on the podcast. How you doing?
I'm doing fantastic. Great to be speaking with you, brother.
Yeah, you too, man. We've talked a lot lately about doing some stuff together, collaborating together, and excited to have you on the podcast. Definitely going to be excited to talk about this topic. And two areas that I really want to focus on today is in the mindset of mechanical ventilation itself. But the first one is I want to really go back to maybe some of your earliest teachings on how to maintain and establish a minute ventilation in these patients in metabolic acidosis, specifically partial compensation. So I want to talk about really, does it need to be in all metabolic acidemia patients? Which ones do you see that we need to make sure that we're setting that minute ventilation, and really all things related to that topic? And then if we have time, I want to dive into the obstructive lung patient.
Sounds good.
So one of the areas from a teaching standpoint that we constantly get asked, and even from a guideline creation standpoint in the critical care transport side, is what should that starting minute ventilation be in that partial compensation patient? And so I want to kind of lead you in three ways, right? Is it a minute ventilation number like 240 mils per kilo per minute? I know that was some of your earliest teachings. Has that changed? Is it just looking at a peri-intubation respiratory rate? Can we target it off of end-tidal CO2? What are some obstacles around that? And is there a pH number that you're trying to focus on in those patients to keep above a certain limit?
All great questions. Where should we start, Eric?
Yeah, let's start with just maybe your earliest kind of mindset on minute ventilation. Which patients should we really focus on from a partial compensation standpoint, minute ventilation wise?
Yeah, I mean, any patient with severe acidosis, if their compensation is what's keeping them at that severe acidosis, then as the compensation gets worse, they have a tendency to slide to the really scary numbers. And everyone's degree of fear is a little bit different. I found it's weird in the intensive care world, because where I trained, less than sevens, where we really started to worry about what's going on. When the pHs were in the sixes, that's not good at all. We better do something with Elacrity. And, I don't want to see a patient at 7.0, 7.1, but it doesn't scare me as much. Some of the intensive care guys on the medical side, they see 7.2 and they're like, this is really bad. And look, something's going on and we should figure out what that is. But that never scared me as much. And I think part of that is there's a belief, I would say a myth, that pressors, stop working suddenly in the face of acidosis. That, in my perusal of the literature, hasn't really been borne out until you're at that severe levels, until you're in the sixes. And a lot of body functions work better in the face of acidosis. So acidosis for me is something to be aware of, something to work towards solving, but I don't go crazy when I see a 7.2. So the patient that scares me is the patient who has a PaCO2 of 30 and a pH of 7, right? Because they've already shown you they're no longer fully compensating. And in general, once they get to the point where they're not fully compensating, their compensation is going to get worse and worse. They don't stay static. As soon as they're not maximally compensating to the real limits of their body, an 85-year-old may not be able to blow down to a PaCO2 of 8. But once they start telling me they can't do what maximum is for them, they're going to get worse. So those are the patients that generally we consider intubation, and then we really have to play with the vent in ways that are helpful rather than deleterious.
With that mindset, is there a starting minute ventilation that you're targeting? Obviously, I know if you have the peri-intubation rate and you know what they were likely breathing, you can calculate that. But let's just imagine this is a critical care transport crew that walks into a small outlying hospital. They don't have that information. They don't get a lot of report from the staff. What would your advice be on starting?
Yeah. So you have two different scenarios, and we've raised both of them, but let's really make them clear. There's the patient that is already flagging, right? They're already telling you, like, the hospital may show you a blood gas they did 20 minutes before you arrived. And again, it's that 7.0, maybe you have a PaCO2 of 35. Maybe they've broken that barrier of now they're hypercapnic in the face of that acidosis. Those should really scare the hell out of you. Like maybe they have a PaCO2 of 50 and a metabolic acidosis with a pH of 7. Those patients, anything you do on the vent is probably going to be an improvement of where they're at. So your ventilator management, while it needs to be good, you can mess up a little bit. You might not have the perfect settings, and that patient will still get better rather than worse because they're already doing such a crappy job, right? Like you take a patient with a PaCO2 of 50 and you intubate them and you don't even put them on really aggressive settings, chances are they're going to be doing better than they were before you intubated them. So that's a very safe scenario. It doesn't mean you don't have the diligence. It just means it's going to be hard to screw that up versus the patient who, for some reason, they're not protecting their airway or their mental status is such that you feel, I can't transport this patient without an intubation. But you look at their numbers and they're a pH of 7 and a PaCO2 of 10. That should scare the hell out of you because that patient, to get them to where they were before the intubation is going to be damn near impossible. And you might have to live with the fact that their PaCO2 of 10 before the intubation is going to be at 20, and that's the best you could do. And that's a situation that happens sometimes. So you could see, Eric, does that make sense why those two situations are just radically different in terms of the alacrity by which you have to, be playing with those ventilator settings on a constant basis?
Yeah, no, absolutely. I think it comes down to, again, the level of experience of the provider, right? How comfortable they are, how, if they're not confident, truly confident at that point with mechanical ventilation in general, and then sometimes not getting all the information that maybe you might have at your disposal. And so trying to be that detective and make the right decision. I think where we've tried to lead people, maybe this is right or wrong, is if you're in doubt on a minute ventilation, set the rate at 160 mils per kilo per minute, right? That sets a rate based on a 6 mil per kilo tidal volume at 26. Now, as I have grown more comfortable over the years in mechanical ventilation and a lot of places are using the Hamilton, but regardless, it's probably more than acceptable to or reasonable to use tidal volumes at 8 mils per kilo if your plateau pressures, if your inspiratory pressures are low enough and that's not a concern, right? To where maybe the rate is a little lower than that, but your volumes are a little higher, right? Trying to offset the dead space that you would get as you raise that rate. Is that ever a consideration as far as
it's not just a consideration, it's a necessity. And
okay.
I think this is a real pet peeve of mine, Eric, and you've really touched on it. The ARDS literature of 6 mLs per kg, I think got promulgated way, way too hard to the point where people think that's a normal tidal volume for everybody. And it's not. And at least in my estimation, there's very few people that should be at that tidal volume. So we're not even talking about a metabolic acidosis person, just normal ventilator management. I start everyone on 8 and I leave them there unless there's something on their plateaus that's telling me that they can't handle that. And almost everyone can. Remember, the ARDS trials were done on patients with severe ARDS, with baby lungs, with tiny lung volumes. So yeah, 6 makes a lot of sense. Everyone for me starts at 8. And very rarely do I have to go below 8 unless they really are a ARDS patient at that level in their initial hours. Because remember, most of your transports are fresh. Now, some of them, you might be taken out of an ICU from a small hospital and they've just gotten much worse. Okay, maybe that's a patient you have to consider much lower tidal volumes on. But for most of the patients your crews are going to be dealing with, they're fresh. Their lungs have not gotten to the point of tiny, tiny baby lungs. 8 should be your starting place. Don't seek the 6 unless you're forced to. And on a metabolic acidosis patient, you got to pick your harm. And them dying from metabolic acidosis is a much more real possibility than them having lung injury from a brief transport. And when I say brief transport, it could be a 2-hour transport. It's still brief compared to 5 days in the ICU. So I would have no problem you starting at 10 on those patients to be able to get them alive from the acidosis standpoint. And then, yes, they could pull it back to 8, as that acidosis starts getting better, as the treatment starts kicking in, as their metabolic demands start fading. So, yeah, it's not just 6 to 8, it's maybe 8 to 10 is a way to play during these early phases of transport.
Man, I love that. Yeah. And I think for me, reflecting on my practice over the years, I think that is, it's hard for me to look at this from the standpoint if I'm actually taking care of patients or if I'm educating new providers. Right. And are there if they're still thinking from a contextual bullet point standpoint versus a more experienced provider that's using analytical thinking and intuitive decision making, completely two different providers that you're educating. And so how you explain that can be two different ways. And I think that's the hardest for me to converge those two mindsets together. But I fully agree with you. Are there ever any times where you utilize, let's talk about the 240 mils per kilo per minute that I know you taught on a long time ago. And is that something you still subscribe to, or have you changed?
Yeah. That 240 really is a extrapolation. So first off, you and I were probably doing 60 to 80 in terms of minute ventilation. And because of the dead space of all the equipment we generally stick on our ventilator apparatus, we generally double that to 100 to 120 once you're intubated. And then, doubling that is a nice starting point for a patient who you want to breathe down. So, if the 120 would get you, and that's, mLs per kg per minute, would get you the 40, the eucapnia, the 35 to 40. And where I want to shoot on most of my metabolic acidosis patients is half that. I'm searching for a PaCO2 of 20. Then it makes sense to double it. But what I would be doing in the ED is I do that as my initial settings, and then very rapidly would check a venous blood gas and see where I wind up. And we'll talk about what to do with people that don't have point of care later on in the show, I imagine. But so that 240 is just a starting place. Now, it's a nice number for me because, like I say, I start everyone at 8 mLs per kg for tidal volume. That means I'm just going to start my respiratory rate at 30 and I don't have to think too much, right? So 30, 8 mLs per kg, I'm in a good starting place. And now I can start evaluating where I'm at. If I'm going to slip up to 10, then of tidal volume, that means the 30 I'm still going to start them at, maybe giving me a buffer of safety, which I like. And now it lets me really say, okay, if they could tolerate that 30 and 8 to 10 mLs per kg, then just leave them there because that's the best you're going to do. Once you start trying to get rates above 30, some patients will let you do it. You can increase their inspiratory flow rate so the breath goes in quicker. You're going to have to sedate them pretty hard. They do not like this. And sometimes they'll let you have it. A lot of times they start air trapping and it becomes counterproductive. So, that's why I say that it's so scary to have that patient with a PaCO2 of 10 just barely hanging on, because getting down to 10 is really tough. Getting down to 20 with a ventilator is doable. And I'd almost say, and this might be a tangential, and you'll tell me, Eric, if you don't want to pursue this, but if it really was that, patient who I'm intubating just for airway protection while they're in the chopper, and they are doing a good job of their own compensation, I very well may intubate them, but not give them paralysis, not give them sedatives that take away their respiratory drive, and just leave them on a demand mode of ventilation like pressure support and PEEP, and maybe augment their inspirations a little bit with some pressure support, but let them do all the work. Let them continue the fantastic compensation they were doing, and see, just with a combination of pain control and then maybe a touch of ketamine just to take the edge off, but not take away their respiratory drive, maybe let them do the work and not try to see how smart I am getting the exact vent settings that was going to do what they were doing. Because if I'm intubating just for airway protection because I'm going to be in the helicopter and I don't want to have to intubate them in the air, then I don't have to start taking over for them until they show me that they're getting tired.
Yeah, and that takes us down a completely different road. And I love that you brought that up as far as the decision to intubate, right? And it might be something that maybe you wouldn't intubate in the ED or in the ICU based on their ability to compensate and your ability to watch them, and maybe that mindset's a little different in the aeromedical side, just based on wanting to be proactive, not reactive. But I think that's something we've really tried to focus on, really in DKA patients specifically, or these patients with usually they don't need to be intubated. Could you support them with high flow nasal cannula technology or non-invasive? So I love that you said that. I think
we should talk about that too.
Let's do it. Let's do it. What are your thoughts?
Yeah. So DKA is an interesting one, and this is the other thing that I kind of stray away from the standard medical intensivist viewpoint, because and look, I'm painting with a broad brush. There are some incredibly brilliant medical intensivists who clearly thought about this far more than I ever will. But they lump all these metabolic acidoses into one box, and they're different. Like DKA, if the numbers are really scary, it's a little scary, but not nearly so much as a septic metabolic acidosis. And I'll tell you why. You could get these DKAs, they're down to like 6.9, but it's purely a bloodstream acidosis. They don't have intracellular acidosis. Their machinery of life function, they're all still working just fine. They just have this acidotic milieu in their plasma. And don't leave them like that forever, but they're on a trajectory to get better. As soon as the insulin starts, the acidosis is going to be moving in the right direction, not the wrong one. You take a septic patient with that same pH, their internal cellular function is going to crap. Everything is shutting down. Their myocytes are getting screwed. All of their machinery of life is failing. Those patients don't take a joke on the ventilator as much. The DKA, you could get away, like you'll have them, they'll be 6.7, 6.8 when you first get them. I don't intubate those patients. Because we know we're going to get them fixed if I can make it through. The septic patients, they're just going to be getting worse and worse. So I can't rely on them to start taking more load than they're already doing. So, that and the same thing with a COPDer who has a profound respiratory acidosis. Their PaCO2 is 150. They're usually fine from the acidosis standpoint. All the machinery is still working. It's a pure, respiratory situation. Their metabolics are not screwed up. They're generally fine. You could put them on non-invasive and get them better, even with profoundly bad pHs. So that's another thing that really, goes into my mindset of how aggressively I need to intubate these patients.
Well, that'll lead us into another discussion here in a few minutes on the obstructive lung patient. But I do want to end this conversation really with the mindset of what type of tools or tricks of the trade are there in, if they don't have point of care testing to evaluate these patients, to clue in to say, hey, yeah, this patient's likely a metabolic acidemia, obviously outside of identifying that peri-intubation tachypnea.
Yeah. So the clinical exam is really rough for this because, you can make a qualitative judgment of like, yeah, they're hyperpnic or they're not, right? Like that you could say, well, it looks like they're pulling a lot of air. But to actually quantify that, there's such an enormous difference between the patient, doing, okay, I could tell they're breathing quickly and they're taking big breaths to, okay, they're breathing 40 times a minute and they're taking 600 cc's of breath. Like there's no way. You just can't. At least I can't do it. I mean, maybe there's smarter people out there at this stuff. So I clinical exam really fails me. I could tell you like, okay, I know this patient's severely acidotic, and I look at them and they're like barely moving any air at all. I'm like, that's bad. They probably need to be intubated. But beyond that, it's really hard. So now you talk about end tidal. Now, end tidal is fantastic when it's higher than you want. By which I mean, if you have this patient, I want them blown down to a PaCO2 of 20 and their end tidal is 35, you got work to do. Take whatever more you can get. If you were at 8 cc's, maybe that's a patient you have to go to 10. If you were at 30, let's see, could I take 35? Could I take 40? If you look down at your ventilator and they're at 20 on their respiratory rate, well, like you're not doing the job. Let's get to 30 and see what happens. Because 35 means, and this is really the take home, the end tidal will relate to the PaCO2 such that the PaCO2 is always at least as high as the end tidal. So if you see an end tidal of 35, then the PaCO2 could be 35, it could be 60, it could be 100, but it's not going to be 20. So when the end tidal is high, then do something. Now, when the end tidal is lower than you want, like let's say, you wanted a PaCO2 of 20 and the end tidal is 8. That doesn't mean the PaCO2 is 8. With an end tidal of 8, the PaCO2 could be 8. It could be 20, it could be 40, it could be 100. There's no way to tell when the end tidal is lower than you want, where they stand. And that's because end tidal is just a conglomeration of so many different things. Their dead space, their shunt, their degree of venous return to the lungs. All of that plays in to that number. So all you could say is if it's higher than you want, do something better on the vent. If it's lower or at where you want, you really don't know where their PaCO2 is or their PCO2. Venous is fine too.
Well, and that is interesting. You brought the lower side up. We spent a lot of time in class talking about that low end tidal CO2. And over the years, I came up with a little acronym called the 3 Ps of end tidal CO2, of basically saying not to chase that number, because what you see in these younger providers is they want to chase and normalize that number to try to make it look good on a chart, right? And so I, came up with 3 Ps. So make sure they're not dead, that they have an actual perfusing pulse. Number 2, what's their perfusion status, right? If perfusion status is crappy, well, that's why it's low. You're going to have to correct the perfusion status for it to return. And then what's the pH? What's the partial? Is there a partial compensation? And again, it comes back to it's a reflection of those other 2 big problems. Don't chase the number. Look at the big picture. So
love it.
Yeah. What about, I know you've taught this in the past, looking at serum bicarb. Is there a way to look at serum bicarb and do some a math equation to say, hey, this is a likely base deficit? If I don't have point of care testing, I only have a Chem 7 panel. That's all I have in front of me. Is there anything that you can use along those lines to clue in to say, hey, I got a problem?
Yeah. I mean, your normal bicarb is 24, right? Some labs, it'll be a little higher. You look at what your lab is, but 24 is a fine number, and you just subtract your bicarb from it, and that's your base deficit. So, you don't need a blood gas to know there's a metabolic problem going on here. And so, yeah, absolutely, you could tell it from a Chem 7. Now, you're going to want more labs to figure out why, but that'll tell you there's a problem.
Right. Okay, awesome. Well, is there anything else along the ventilation standpoint that you want to hit on that we haven't hit on? And then if not, we'll move into obstructive lung patients.
Yeah, I guess the last question, the really contentious one would be like, should we be doing medication compensation for this? At what point do we give bicarb? And
let's talk about it.
Yeah, I'm not an enormous fan of pushing bicarb, but if the patient could tolerate IV fluids, it makes a ton of sense, I think, in a patient like this, if you're going to give fluids, to make them as maximally alkalotic as possible. And there's nothing more alkalotic than a bicarb drip. So if you are taking from a place where the patient is getting fluid, asking them, or maybe you have the capability of just mixing up your own, just switching those fluids out from normal saline, which is acidotic, or lactated ringers, which is for all intents neutral, to something that's actually going to make the problem better long term, and just put them on an isotonic bicarb drip. 3 amps of bicarb and D5W, or sterile water if the pharmacy's mixing it for you, makes a lot more sense. Now, let's say they just don't have the space for fluids. Then I still don't like pushing bicarb, but then letting an amp of bicarb run in over, 10 or 20 minutes, probably is not going to hurt too much for, because again, the risk benefit of transport is different. Like, okay, let's say later on from that couple amps of bicarb we infuse in, the patient gets a little alkalotic, their DKA resolves. All right, well, that's less of a problem for me than them dying in the transport, right? Versus
right, I
have them in the emergency department ICU. Now I could be really perfect because I have all the tools at my disposal. I could do, Q 30-minute blood gases and figure out exactly what they need. So transport, there's a lot more space to say, like, yeah, we made them a little alkalotic, but we kept them alive, versus, let's make everything perfect. Like a true maximum VMS is perfect is truly the enemy of good, right? Like we really could hurt ourselves by overthinking stuff. So I don't have a problem with it as long as you're not pushing it. And the reason you don't push it is there is, first of all, just dissolved CO2 stored in the glass ampule of the bicarb. So they just immediately get a burst of that. And then there's a conversion of the patient's various plasma milieu to CO2. So you just basically get this intense burst of acidosis that rapidly dissipates, but that might be enough to tip them over the edge. So I never will push amps of bicarb unless it's like a tricyclic overdose. But I got no problem if the pH is in the 6s, and that's really where, for me, that's where I want to get something on board. If the pH is in the 6s, to just give them either a really slow push of the bicarb over, like if you can make yourself have enough patience, I can't, over 5 or 10 minutes, or better yet, just put it on a drip set and just let it drip in over 5 or 10 minutes. That's absolutely a great way to go.
Well, that's interesting. We just had that conversation with Lori and I on maybe a program change with one of the companies that I work with, Apollo MedFlight, and we were just debating on what that pH number is. Is it less than 7.2? Is it 7.1? Is it less than 7? When would it be advisable and when not? So I'm glad that you brought that up. Awesome. All right. Other big area, and seeing a lot of this, probably one of the areas that I see the most in when I teach horses from a misunderstanding standpoint is the obstructive lung patient, right? Obviously, from a standpoint comparison, injury versus obstructive approach, you're going to get a lot more injury approach patients. People are pretty comfortable with that approach. And where I see the mistake is not remembering to lower the rate, right? And so I want to talk about really the mindset of, education-wise, we focus a lot on the expiratory phase. And I'm seeing this. I know you have done teaching on this. Let's talk about the inspiratory failure side and how important it is to give credence to them together in identifying a proper ID ratio.
Okay. So it's funny because I talk about the inspiratory and expiratory side of obstructive lung disease a little bit differently, though what you've brought up is really a fantastic point as well to discuss. But when I was doing most of the teachings about this, I had noted a cohort of patients, especially with severe asthma. This was really the ones I saw it in, where classic asthma, they can't exhale. And eventually that's enough to cause air trapping. And then they just can't get any tidal volume in. And that's the classic failure mode of these bad asthmatics. And it was always, we need to give them more time to expire. We need to give them more time to expire. And a lot of those patients gave you no choice. You had to intubate them because they just, their respiratory muscles were not strong enough to breathe in against the enormous, pressure that had been created in their lungs. And I saw those every now and then, but incredibly infrequently. By the time, I was out, patients were getting pretty good therapies for their asthma. They, all had inhalers. A lot of them were on inhaled steroids, which I think were an enormous game changer. And all of a sudden, I didn't see patients like that very often. And yet I still saw a ton of severe asthmatics. But the severe asthmatics I saw, their problem was not that they couldn't get breaths in because of lung problems. They weren't having enormous amounts of air trapping. It was just they had gone through this cycle of a little bit of hypercapnia, a little bit of acidosis of the respiratory musculature fatigue, and then that made their hypercapnia worse. And they just kept cycling. And some of it was just real trepidation about the fact that they couldn't get air in. And so they weren't doing very good, relaxed ventilatory dynamics. And as a result, we'd have these patients, they look like death. They'd come in all the time. And if you wanted to, you throw a BVM over their face and squeeze. There was no resistance. There was no, some of these bad asthmatics of that first category, their chests were like stone. You'd squeeze a bag and the mask would pop off their face. And then you'd have someone hold a 2-hand mask seal over their face and try to squeeze the bag and the mask would still pop off their face. Or you'd be squeezing a bag that felt like, rock. You couldn't squeeze it. But these patients weren't doing that. No problem getting the bag squeezed. And what I realized is they had just had pure inspiratory failure. They had just gotten to the point where they couldn't do the work, but their lungs would happily take the gas. And we just stopped intubating those patients and we just put them on non-invasive. And a lot of them would get better because all of a sudden they have augmentation of their inspiration. Some of them wouldn't because it just freaked them out. They were again feeling like they were going to die. And we would just give them ketamine. And then all of a sudden they'd have no markers of obstructive disease on the non-invasive machine, right? Like there would be no high pressure. The breaths would just go in with no problem at all. And so this was the lion's share of the asthma I was seeing. So I stopped intubating most of my asthmatics. So the ones you were asking about earlier after my diversion, Eric, were the ones who were in that first category. Because if you're going to intubate them, they damn well better be in that first category. They better have something else going on that's forcing your hand to intubate. Because otherwise, non-invasive works great. So now you get these severe asthmatics. They have air trapping. And we're going to have a big problem ventilating them. Because A, we have to let the gas come out. And to your initial question that spurred all this, we have to get gas in, but we have to get it in quick enough to still give them time to get the gas out, right? Like, so that's our primary thing is give them time to exhale, should be our watchword. Check that they're being given ample time to exhale, and then work on the inspiratory side such that it's not stealing any of that time to exhale.
Yeah, and where I've seen this is with the organization I brought up earlier. The chief medical officer. He's obviously gets calls all the time, and in some cases, on some of these severe cases, he will actually patch me through on online medical direction and just try to hear what the crew has. And I've seen this quite a few times now, where part of it is that maybe their rate was set a little too high, but which obviously shortens their whole respiratory cycle and their ability to adjust IDE. But I've seen this in the pediatrics where their rates, were still set much higher than the standard 10 to 12 because of their age. And the IDE ratio was lengthened so far that their I time was a half second, right? And you just can't fill the lung based on a 240, 280, 300 mil tidal volume in a half second. And so that's where I've had to just advise, hey, let's lower the rate. And quite a few times turn the ID ratio to a 1-to-1 ratio. So I really want to talk about that mindset, what your thoughts are. When do you deploy that? Some of this stuff for me is just kind of winging it on the fly, and obviously having used it in my personal practice as a flight paramedic, but it has seemed to work. It doesn't seem to be a problem if they start out with a standard rate of 10 breaths per minute. They have a 6-second cycle time. Usually that's not the issue. It's the higher rates, younger patients with intrinsic rates that are higher.
Yeah. It's funny because if I'm going to intubate an obstructive lung disease patient in the early period, this will change in the ICU later on. But, what's relevant to your listeners is that early period of ventilation. I want these patients heavily sedated, right? Like, so we're really being given a unique opportunity because most of the time we'll leave patients light, and now their spontaneous respirations are going to get in the way of all of our machinations on the ventilator, right? Like, they're going to interfere. So these are a fun patient group because I could really I own their lung dynamics because I'm snowing them with propofol and opioids because I want them to have a period where I could just get them better. So they're going to let me do what I want. And in those circumstances, I could get in an 8 cc breath in half a second by increasing their inspiratory flow time to the point where, those breaths go in very quickly. Now, a patient who's not heavily sedated won't tolerate that. They hate that, but you can get a ton of tidal volume in a half second if you have adjusted your inspiratory flow rate. Some of the ventilators don't let you have direct control over that, and that's a problem. But most of the time I'm starting at 8 cc's per kg, just like I was before, because the mistake people make is they're like, oh, well, a 6 cc breath will take less time, and it will, but so much of that breath by proportion is dead space, right? So each time you add a cc to that 6, you're getting more actual usable respiration versus the dead space. The dead space is a fixed amount. So these low tidal volumes, most of the breath is dead space. So I'll start them at 8 cc's per kg. And then I will empirically increase my inspiratory flow rate to 100 on these patients if the ventilator allows me to adjust it, and sometimes 120. And, we've really, I think, hurt ourselves with this idea of IDEs. I don't think you should be looking at IDE. That sends people astray. Because first of all, on a really bad patient, if I have a half second inspiratory time and I have, 6 seconds, my IDE is like what? 12, and that's what they need sometimes. So I think IDE sent us all astray. I was taught that, and I think we should stop talking about it. What we should look at is choose a reasonable strategy of ventilatory management and then check your work. And if you don't know how to check your work, then that's really the big problem. And, you could either do your flow waveform on your vent if you know what to look for there and you know how to magnify on the vent. It's really key. You can't really see it very well unless you zone in to that end of expiration and see if they're really hitting the zero line. Or you have to know how to measure a plateau pressure, right? And so if you're able to do that, then you could absolutely have a very workable management in a volume control mode. If you can't do those things, then maybe we should be in pressure control. And that is a little bit scary because you can really, if you're not monitoring their minute ventilation adequately, get them in a bad place. But I think if you don't know how to check your work on a volume control mode, then it's probably safer to put them on a pressure control mode.
Well, and that opens up another conversation. Obviously, the majority of the critical care transport industry has moved to the Hamilton T1, which is always pressure, right? There's a volume adaptive or pressure-related volume control mode. So they don't really have a choice. And where I've seen this in classes, I'll use pig lungs, and I've got a set of pig lungs that are got dye in them that really do air trap. A couple things I see consistently, and I've seen this also on online medical, is the mindset of let's keep a PIP at 35, which is unrealistic in that patient, and then not understanding or remembering that your ventilator is set at a high pressure alarm at 35 default, and it limits the breath at 10 below that. So what I've seen is they're never reaching their exhale tidal volume is never reaching their target volume, and they're scratching their head on why that's happening, right? So that's the kind of two things, right? They're having to use pressure, which is, I guess, fine. I mean, they don't have any other way to do that. And then they're not understanding that they've got to turn that pressure alarm up and get it out of the way. So what's your mindset on that?
Yeah. You hit on really one of the key points, and one of the really clean ways to kill a patient is in this obstructive, you have to have your pressure limit set way high. And I don't really care whether that is, because especially if you're going to put them on a, PRVC type mode, which is what I think most people are going to be using on the Hamilton T1s. That's fine. Set a reasonable desired tidal volume target. Again, that 8 cc's per kg, and then set your pressure limit through the roof. Sometimes in order to get a breath in fully, and you really want that, you really want to look at your vent and make sure there's no pressure limit alarms. Knock them up to 80 or 100. You have to do it. You can't ventilate these patients any other way unless you have that PIP limit high up, and that's not going to be the plat, right? Like all of their pressure from that PIP being high is the resistance portion. It's that large airways before the alveoli. You're not going to do any damage to those patients. You just got to raise that alarm. And we see this in the hospital all the time. These patients getting these curtailed breaths, and they could have a hypercapnic death as a result. So yeah, you've hit the key issue. If you're going to be using that kind of ventilator, make sure your PIP is set way, way high.
All right. Last little question on this type of patient, a question I get all the time is, what's the role of PEEP? Is there a role? What are your thoughts?
It's such a contentious issue. For the asthmatics, I don't really think there is in the early phase. So you got to understand, PEEP's doing two things in this situation. In the first one, and this is really, it's more theoretical than actual, I think, in most patients, but they have this idea of stenting the airways open. And this might have increased relevance in a COPD patient who's really just destroyed their pulmonary architecture, and they might not have the normal structural integrity to keep those passages to the alveoli open just through normal lung dynamics. And so in those patients, I like a little bit of PEEP. Generally, like you could fuck around with expiratory holds. Are we allowed to curse, Eric?
That's fine.
Okay, great. I figured the medics wouldn't have a problem with it. You can mess around with expiratory, trying to figure out a number. It's really tough. It's just easier. Just put them on 5 a PEEP. I think you're fine in those COPDers. But in the asthmatics, their lung architecture is fine. So now really the only reason you do it in an asthmatic is the second reason. And the second reason is that they have to overcome their intrinsic PEEP, the PEEP generated from their air trapping, in order to trigger the ventilator. That shouldn't be an issue for the transport folks or for early on in the patient's course, because they should not be triggering. They should be snowed. They should be so deep down that it's not really an issue. So for me, I'll put my asthmatics at 0 of PEEP. And then if the resident comes and puts them on 5, I don't care. But if they're going beyond that, then it's a problem. It's going to start interfering with things. But as long as your set PEEP is below your intrinsic PEEP, it's not really going to affect them negatively at all. But really measuring intrinsic PEEP is hard, especially if the patient has any spontaneous respirations. And if they don't have any spontaneous respirations, then you don't need the PEEP because they're not going to be triggering. So it's not necessary. So on my COPDers early on, I'll put them on 5, on my asthmatic 0, and that's the way I play it.
All right. Well, I think we've covered a lot of stuff. Is there anything that you think we've missed that you want to hit on?
It's not as complicated as people will make it seem early on. If you get a really fundamental set of basics down, you're going to be doing a good job for these patients. The way we screw up is things like not adjusting your PEEP alarm or putting them on, 14 cc's per kg tidal volume, which no one's going to do anymore. This is not the 1970s anymore. So, just keep them alive. I guess the last point I'd make that we didn't discuss, because it wasn't really pertinent to a lot of the things, but I want to get it out there, is I don't want to see a patient on 100% FiO2. That's a failure, because it will allow you to get the numbers you want on their saturations temporarily at the expense of like continued de-recruitment of their lungs. And so if you have to just empirically put them on something, you don't want to mess around too much, just start them at 50 and now adjust your PEEP to a reasonable oxygen saturation of greater than 90. And then don't start knocking up your FiO2 until you're knocking up your PEEP as well, right? So I'll start most of my lung injury patients on a PEEP of 8 and FiO2 of 50%. And that's a wonderful place to be. And now if I want my FiO2 to go up, I got to do it stepwise. FiO2 goes up a little bit, PEEP goes up a little bit, FiO2 a little bit. And there's tables for this, as you know, Eric, but you're not going to remember them in the field. And maybe a really smart medic or nurse will have that table. You don't need it. Just know if you start them at 50 and 8 and then work your way up, a little bit up on the FiO2, a little bit up on the PEEP, you'll be fine.
Can you really quickly go through, because I know that we'll have questions, how does increased FiO2 cause de-recruitment? Yeah,
it might, theoretically cause de-recruitment by just the fact that the alveoli are going to collapse. They've lost their surfactant. And so now you're going to have absorption atelectasis from that FiO2 getting absorbed, the nitrogen's near the stent. That's purely theoretical, and I don't think it plays an enormous role, though there have been studies saying it has some contribution. That's not it. It's that if you have a patient whose saturation is 82% and you fix that by putting them up to 100% FiO2, anything beyond 40%, you have taken all of the real benefits of dead space out. After 40 or 50% FiO2, you've eliminated dead space as a cause of their poor saturation. So all that's left is shunt. And yes, you could take a patient with shunt physiology, pulmonary shunt physiology, and take their sat from 82 to 90 by knocking them up to 100 FiO2 for a half hour. But during that half hour, what has happened is whatever was causing the shunt has continued, not to just stay the same, but get worse and worse. So you have temporized the numbers while the actual condition that the patient is going through has gotten worse. Now their lungs are that much worse a half hour later, versus you've gone up on the PEEP along with your FiO2. You've now given them the nidus for that shunt to get better through alveolar recruitment. So that's why. So it's not that the FiO2 itself necessarily is making them worse, though, again, there is a physiologic basis for that, but I'm not going to put my money on that. I'm going to tell you, you just haven't made their intrinsic problem that was giving you that 82% sat any better. You've just hidden it from yourself for a little while. Why what you should be doing is changing what's causing that pulmonary shunt.
Yeah, it's exactly similar to what we talked about with end-tidal CO2 and chasing that number and not hitting on the underlying issue. Yeah, absolutely. Well, brother, this was an amazing podcast. I really appreciate you taking the time to join us. Look forward to doing other projects with you.
Yeah, for sure, man.
Yeah. As always, I'll put Scott's contact information in the show notes. And if you have any questions, we will talk to you soon.
Love it.
This has been a production of the Flight Bridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.